Next talk, I invite ocular surface surgeries and corneal procedures in wetlab. Dr. Irshad Edavana, Assistant Professor in Malabar Medical.
So I will just discuss about some methods to regarding the ocular surface surgery and corneal procedure that can be practiced in the wet lab. Delicate tissue handling is needed for all ophthalmology procedures. Some surgeries what we can do in wet lab practice, one is corneal suturing, penetrating keratoplasty, lamellar keratoplasty, refractive surgery, etc. So one additional thing we require for this one is artificial anterior chamber, and the rest all other things are described by Raj sir. So suturing is most vital skill required for all ophthalmologists. We have to get a pre-wet lab reading and detailing about how to place the suture consistently. Second one, a pre-wet lab reading and training regarding approximate wound tie knot consistently. We should have a hand position with a maximum stability. So that should be the pre-requirement for a good wet lab practice. We know there will be a tremors for the beginners while doing the surgeries in the microscope. Why this tremor happens? Tremor happens not from the hand muscle, it happens because the muscles that's from the wrist to forearm or way up to the shoulder girdle. How to reduce this tremor? You keep the elbows close your trunk. Second one, keep the wrist in a neutral position related to the hand. These two positions actually help us to reduce tremor. Third one, you can keep your rest of the um, hand on a forehead or any surface. That also help us to reduce the tremor. So when we practice the suturing techniques, suture entry position should be equal on both sides. Straight suture starting should be a straight suture perpendicular to the wound and should pass equally depth in both sides and should be a very good apposition without undue compression. For keratoplasty and corneal suturing, usually we take 1 millimeter from each side, and this should pass almost 80 to 90% of the stroma. Same depth in the other side, and we take the needle and pass it out. After suturing, the guide or the mender has to check for the host length, radius of the suture, depth of the suture, length in the graft side or the other side of the suture, radius, how radial is the second exit, compression, and it should be graded. And this should be done routinely in each wet lab practice or each time, and we can monitor the gradual improvement in the suturing techniques. When we talk about penetrating keratoplasty, we can use trephines, either handheld trephine or we can use automated trephine. That trephine the graft and host cornea, and we can master the suturing technique. This is a keratoplasty in our wet lab. So you can see the radial sutures, and this can be done by comprehensive ophthalmologist or anyone who wants to practice keratoplasty. So this wet lab should be there in all hospitals, not only in teaching institutes, to learn new techniques or new type of surgery we want to practice. So you can master the radial incisions, length on each side, compression on each side, actually help to improve our outcome. For lamellar keratoplasty, the cornea should be mounted on a artificial anterior chamber. So harvest the cornea, either a tissue that is not using for our patients like a penetrating keratoplasty or a lamellar keratoplasty, or you can use a cornea from a bull's-eye or a goat's eye or a pig's eye, and that should be harvested and placed on an artificial anterior chamber. And do anterior and posterior lamellar keratoplasty. actually we can refine the cornea. You can do a big bubble technique. You can uh, practice suturing technique on this wet lab. For an endothelial keratoplasty, you have to attach a anterior chamber maintainer to our this artificial anterior chamber and practice regarding the graft insertion technique like pull through, gliding, any new method you want to, or bosin glide can be mastered by using a wet lab. Refractive surgery, practice of flap creation, flap repositioning, ironing, everything can be learned through the wet lab practice. This also require a artificial anterior chamber. Ocular surface surgeries are actually easier to practice compared to the other corneal surgeries. So, as Irshad discussed, we got the amniotic membrane from our gynecology department. You just keep the amniotic membrane over the cornea, either the artificial anterior chamber or a whole eyeball, and you can practice the suturing, you can practice inlay technique, overlay technique, multiple layer technique, everything. And for the SLET or limbal stem cell transplant, we can harvest the limbal stem cell from the donated cornea or from the pig's eye or bull's eye, and you can do cutting of the limbal stem cells, attaching of the limbal cell. If you have a fibrin glue, you can attach the limbal stem cells all over the cornea and practice the use of fibrin glue. Thank you.
Yeah, describe how the sutures on the cornea has to be perfectly done. How the initial period students may have some problem with stitching and suturing and how it can be tackled. Everything has been well explained.